So today for Menopause Month, we are talking to Dr. Susie Unsworth, who is a GP with a special interest in women's health. Susie, if you'd like to introduce yourself.
Hi, so I'm Susie Unsworth. As Emily said, I'm a GP who primarily sort of has an interest in women's health, and menopause is one of the areas that I have a really strong interest in. I am hoping in the coming months to be setting up my own service to offer some menopause care, but I'm really pleased to be part of the Perimenopause Hub now, so that hopefully I can offer some advice and support right now to you all.
Awesome. So over the course of this webinar, we're going to discuss HRT and how it's used and how it helps, etc., etc. And I think as a good starting point, it's probably worth just going through how the monthly cycle works so that we understand where the hormones kick in. Is that a good starting point?
Yeah, I think it's quite useful to have a little bit of an understanding as to what's happening with the hormones in your body throughout the cycle. If you go online, there are some really quite nice diagrams that show you a lovely graph of what's happening with your hormones. And what I thought I might try and do is maybe just sort of briefly explain one of those diagrams to you. So if you start with sort of the first day of your cycle, which we count as being the first day of your period, your estrogen level is a little bit on the low side, and it slowly starts to increase as the days go on towards ovulation, and then it reaches a peak at around the time of ovulation, and then it drops down, and that's when you ovulate essentially. After that, there's then an increase in progesterone, which is supporting the lining of your womb in preparation for any fertilized egg to arrive in the womb and then form a pregnancy. If an egg isn't fertilized, then the levels of progesterone then start to drop down again, and that's when you start to have your period essentially, and then the cycle starts over again. So the average length of time for that is about 28 days, but that can vary somewhat from somewhere between sort of 25 to 35 days. And as long as it's happening in a regular pattern, that is usually quite a good sign that you're ovulating. There are other hormones involved, so there are other hormones. You probably hear things such as LH and FSH being sort of terms being bandied around. So that stands for luteinizing hormone and follicle stimulating hormone, and they're also involved in the ovulatory cycle as well. It's a little bit more complicated, but as a basic overview, that's how I would sort of explain it to someone.
Okay, cool. So then when we're in perimenopause, obviously our cycle goes here, there and everywhere, and we're sometimes not ovulating in a cycle. So presumably that then puts the estrogen and progesterone out of kilter.
Yeah, exactly. And that's often why around the time of the perimenopause, your cycle length can fluctuate. So sometimes it can be a lot longer than you expect, and sometimes they can be a lot shorter than you're expecting. And it is all often due to whether or not you've actually released an egg during that cycle or not. So we don't get too concerned if they do start to change in cycle length. The only time I'd probably be slightly worried is if you were getting a lot of intermittent bleeding in between, and that would probably encourage me to want to sort of think about things a little bit more. But yeah, a shortening of the cycle length or a lengthening of the cycle length is not uncommon around the time of the perimenopause. It's quite tricky though, isn't it, when you kind of say, oh, it might get shorter, it might get longer, you know, it could do one or the other, and that can fluctuate over quite a long period of time.
And I have to say, I've noticed personally that having an app on my phone so I can track where I am in the cycle gives me a much clearer feeling for what's going on. So I know a lot of women have that, you know, you spot the signs that you're ovulating, and then you notice when you're in that PMS mode and you're like, okay, step away. And then you have the chocolate craving day, and it's like, okay, I know where I am in the cycle. And I think that there's a lot to be said for tracking it, isn't there? So that you
I think that can
see
be really
where you are.
Yeah, I think that can be really helpful. Yeah, just like you say, so that you can see where you are and also what to expect. Because I think part of the problem around the sort of time of the perimenopause is kind of all these unexpected things happening. And I think if you can do something that helps you prepare for it, then often you can manage how you feel a lot better if you're expecting it rather than it feeling like it's just coming out of the blue.
Yeah, absolutely. So moving on to HRT.
Mm.
I know this is quite a large topic, so we'll try and keep it simple. What are the different options out there, and why would somebody use different types?
Yeah, sure. So I always think of HRT as maybe being divided into whether you can have just estrogen on its own, or whether you need to have a combined form of HRT, which includes estrogen and then some form of progestogen alongside it. And I think some people find it a little bit tricky to work out which one of the two they should be having. But a really sort of straightforward way of thinking about it is, if you still have your womb, so if you've never had a hysterectomy, if you've still got your womb, then you do need to have a progestogen element of your HRT. And the reason behind that is, if you are given estrogen exogenously, so separate from what your body is naturally producing, it's going to stimulate the lining of your womb to build up. And if you're given that unopposed, completely on its own, then the lining of the womb can just continually build up. Now, what can happen in that situation is that any process where there's continual sort of dividing of cells, which is what is happening when your womb is building up, errors can occur in the division process, and then the cells can sometimes become abnormal. And so over time, having estrogen without any progestogen alongside it increases the risk of abnormalities occurring in the womb and it overgrowing, essentially. So if you have a womb, then you need to have a progestogen alongside it to prevent that process from happening. And it can be given in two ways. So if you're still having periods of any kind, even if they're quite spaced out, you really should be having a form of HRT that gives you a bleed of some kind. Now, it doesn't necessarily have to be a bleed every month. So there is a type of HRT which gives you a bleed every 3 months. But as long as you're having some sort of bleed to allow that lining to sort of shed away. However, if you've reached a point where you're not having periods anymore, so it's been 12 months since you had a period, you can actually have your progestogen continuously so that you don't bleed at all. And it's a lower dose that's given on a sort of daily basis, just to help maintain the lining, preventing it from overgrowing.
Okay. So in somebody who has a womb and needs both, what are the options? So for both the estrogen and the progestogen, can they both be oral? Can they both be patches? What are the different options?
Yeah, so there's actually quite a lot of different ways in which you can take HRT. And I guess traditionally, the way it was always given was in a tablet form. And if you're taking it in a combined way, there are tablet forms that can be done in a cyclical way or a continuous way. So in the cyclical form, you'll have usually 2 weeks of tablets that just contain the estrogen, and then 2 weeks of tablets that contain your estrogen and progestogen, and that they tend to have a sort of 2-week cycle, and that's what matches your kind of average 4-week cycle that you would be used to. If you're taking it in a continuous way, then every tablet contains a small amount of progestogen and the dose of estrogen in it. However, there's not just tablets available now, and actually a lot of evidence is showing that providing your HRT through the skin is actually a much safer route. It reduces the risk of blood clot problems particularly, and so in women who maybe are higher risk for that sort of issue, they would want to consider having their HRT given to them through their skin. And there's also different ways in which that can be delivered. So there are patches that exist. And again, these can be in a cyclical form or a continuous form. There's a gel that you can use. And then if we're thinking about other ways of delivering the progestogen, there are body identical forms of progesterone, which you can take orally, or then you've got the Mirena coil, which can deliver your progestogen directly into your womb. So there's actually lots of different variations on how it can be delivered, and there's definitely a way that is going to suit most women if you can just discuss the different options.
And what would be the contraindications for a woman not being able to use HRT?
So, I mean, I personally feel there aren't that many absolute contraindications to HRT. I mean, if a woman has actively had a blood clot herself and she's known to maybe carry some genetic predisposition to blood clotting, the evidence of the safety of HRT really comes from women who don't have a high risk for blood clot. And so the evidence where it's shown that delivering it through the skin is much safer and actually doesn't offer an increased risk, it doesn't really include those women who are already at risk because they've previously had a DVT or a PE or some other sort of blood clot problem. So I guess in those women, you'd have to really counsel them about the risks and benefits. But I think, as with anything, I don't think we should ever say that someone can never take something. I think you kind of have to weigh up the benefits and risks. And I think if somebody is so severely, troubled by their menopausal symptoms and they literally just cannot cope with it, they may well be willing to take that risk that, yes, this potentially could cause a blood clot problem, but she can't go on living the way she is, and they have to, weigh up the pros and cons. And I suppose the same applies with someone who has a history of breast cancer. So obviously a lot of breast cancer can be hormonally driven. And obviously there's been a lot of scare in the media recently about the link between HRT and breast cancer. So I guess women with a history of breast cancer, again, you'd be thinking, is this the right treatment for them? But again, I don't think I would ever say that they can never have it. And I think you have to kind of just do it on a case-by-case basis and make sure you've had an in-depth discussion about the risks, the benefits, and other alternatives, and then hopefully the woman can make an informed choice as to what she wants to do.
And am I right in thinking that certain types of HRT will cause issues if somebody smokes, or if they're beyond a certain amount overweight and things like that, or is that?
Yeah, so I suppose we're looking at kind of risk factors really. So I guess when we were just talking just now about the increased risk of blood clot problems, so if you're a smoker, you're putting yourself at an increased risk of a blood clot already. If you're particularly overweight, if you have other metabolic problems like diabetes, all of these things increase your cardiovascular risk. And I suppose looking at the HRT, you want to give them an option that's not going to further increase that risk for them. So usually oral preparations tend to have an increased risk associated with them. So in women who were already at a higher risk, I would always encourage them to think about a route through the skin, which we'd call a transdermal route. But again, like we said, there's different ways of delivering that. There are other women, so say women who suffer with migraines, often HRT can sometimes trigger migraines, particularly if they found their migraines were very menstrual related. If you give the HRT through the skin, it gives a much more constant, gradual dose. And actually that can often be better for women with migraines, rather than having a tablet which gives you a big peak in the dose when you first take it, peak in your blood level when you first take it, which can sometimes be what can trigger the migraine. So if you can give it more constant and gradual, then sometimes that can be a better way.
And one last question: if somebody has tried using birth control pills over the years and has really not got on with them, I know some women then worry that because HRT is also a hormonal therapy, that they might not be able to use that because they couldn't get on with the pill. Is there a correlation or not?
Well, there's quite a difference between HRT and the contraceptive pill, and one of the biggest differences is the estrogen level the estrogen that is used. So in HRT, it's a natural form of estrogen, which is essentially identical to what our body produces. In the contraceptive pill, it's a synthetic form of estrogen, which is called ethinyl estradiol, and it's a much more active form of estrogen, because it needs to be for the pill, because you're obviously wanting to stop people from ovulating and you know, act as contraception. So it needs to be a hormone that's going to be really effective. The problem is that it's a much stronger form of estrogen. So if you're going to get symptoms, you know, it's probably because it's quite a strong form of hormone. In HRT, it's a much lower dose and a much more natural hormone. So I will often say to people, just because you've had a bad time with the pill, it doesn't mean that that's going to be the case with HRT. And actually, if we can choose a form of HRT that more or less matches our natural hormones, which we can prescribe quite easily, then hopefully people would get on a lot better with it. I mean, obviously I can't say for certain. Some women who are very sensitive to hormones, unfortunately, will get some side effects from it. But I would say for the majority of people, that is not the case.
Perfect. Thank you so much. That was really, really informative. When I put this video up, should we put one of the graph, like you were saying about, we'll put that in the comments with it?
Yeah, to try and find a good one and send it to you.
That would be great. And then any questions anyone's got, I'll pop this into the Facebook group, and any questions anyone has, they can ask away. And once your clinic is live, then everyone can come and see you and get their prescription.
Yeah,